Again, this is Hunter Gatewood with the California Improvement Network, which is a learning community that extends across California and even beyond with multiple activities for improving population health. And if you want more information about the CIN, especially if you didn't get announcements, if you don't get announcements directly about CIN activities, we encourage you to go to chcf.org/CIN and sign up for the emails that come with all sorts of opportunities like this webinar today. Today's webinar is on using cost of care data to achieve the triple aim. A lot of good work going on in California and nationally to achieve cost of care data and then to use it for improvement. And we have two great speakers on the line with us today. We are recording. We get at least equal uptake on our CIN webinars from people who listen to the recordings as who join us live. So we'll have the recording up, and people do take good advantage of that. Please share it with your friends and colleagues. Again, if you chat to host or organizer now for logistical questions, if you're having problems getting connected, and then at any time too, please use chat for our speakers to get questions. We'll be monitoring the questions as they come in, and we'll get to as many of them as we can towards the end of the hour. There will also be a survey. We want to hear what you thought about this webinar and also get your ideas for future webinar topics through the CIN, and there'll be a quick survey that goes out immediately following the session today. We'd appreciate it if you would answer those 3 short questions for us. That would help us a lot to keep making sure that these presentations are valuable for you. All right, let's get into it. So today we are lucky to have Diane Stewart and Naomi Fuchs join us. Diane will be speaking first. She's the Senior Director at the Pacific Business Group on Health, where she's been since 2001, so 15 years there now. She directs their healthcare improvement initiative called the California Quality Collaborative that produces many programs, many exciting and important programs to improve care in outpatient settings, working in partnership with health plans, medical groups, and employers. She was the main, maybe one of the top 2 or the top architect of this California Improvement Network that's bringing you this webinar today. One of her things that she has done in her career. In addition, she led the technical development team for the Integrated Healthcare Association's Pay for Performance program, and she's also held numerous positions at IPAs and medical groups, and including some in the northeast part of the country. Naomi Fuchs here is the CEO for Santa Rosa Community Health Centers, where she's been in that role since 2002. As part of a 30-year career in healthcare executive management. While she's been there, under her leadership, the clinic has grown from serving 5,000 patients at one location to more than 45,000 patients at 9 different sites. She participates in many countywide organizations and stakeholder committees, including the Redwood Community Health Coalition, the statewide California Primary Care Association, Health Action, and the Committee for Healthcare Improvement. So 2 very accomplished professionals to share their learnings and wisdoms with us today. And we are going to start with you, Diane. I'll advance your slides for you.
Thank you, Hunter. Welcome to everybody here today. I'm going to start by offering a definition for total cost of care, then use the CHCF California Regional Healthcare Atlas on cost and quality to talk about why cost of care varies, and then introduce how cost of care is increasingly entering contracting arrangements with providers. And then finally share with you what we learned through best practice interviews with 15 organizations around the country on how they're approaching managing total cost of care. The summary is also on the CHCF website. And then hand it over to Naomi, who can speak directly to her experience over the past several years managing cost of care. So first of all, what do we mean when we say total cost of care? We're defining it as the total medical services consumed by a general population of patients. This means the cost for all healthcare services, inpatient services, outpatient services. It might also include pharmacy and mental health services, used by a population of patients. And a population can be defined by a community. For instance, we could calculate the total cost of care for San Diego County and 3.2 million residents. or we could define it within as a contract, a health plan contract, to determine total cost of care for 8,500 ACO patients, for instance. And then the per capita cost is simply the average cost for that population, total cost of care divided by the number of patients. Okay, Hunter, let's advance, and we'll take a look at some real numbers on cost of care. So this is a snapshot from the CHCF Regional Atlas, and let's take a look at how per capita cost varies for this population. The population you see displayed here is a community. It is Medicare HMO patients, so it's patients over 65 years old who are enrolled with any of the Medicare HMOs in that county. And we can see that the cost of care, or the per capita cost, varies from a low in San Diego County of about $11,000 per person to a high in the eastern part of LA County of $14,500. That's represented in red at the highest cost per capita, and the lowest cost per capita is in dark blue. You'll see that in San Diego County as well as a few other parts of California. So why would average cost per capita vary? There are three main reasons, and all I think are relevant to any provider organization that is interested in beginning to enter contracts that include cost of care. Number one, the demographics of your defined population definitely affects the total cost of care. We would expect the average cost of care for an over 65 population to be greater than an under 65. And in fact, that's the case. If you play around on the CHCF website, you'll see that the average cost of care for commercial populations below the numbers we're looking at here. But there's not much we can do to manage that. The second reason are variation in local practice patterns. This is really the aha of much of the work done by Wenberg and began at the Dartmouth Atlas, and which is now replicated for us here in California. Local practice patterns, or the number of services used for the same demographic population, varies tremendously, and there's some great examples, again, on the CHCF website of 3- or 4-fold variation between cardiology procedures, for instance. And finally, the last reason we might see differences in care is the cost per service. So even when the number of the cost for an MRI might vary regionally, a cost for a hospital day might vary. So those are the three main reasons cost of care, total cost of care might vary. Let's move now to the next slide and take a look at how cost of care is finding its way into contracting arrangements. And you'll see on the upper left corner, fee-for-service patients, Medicare is contracting with delivery systems for ACO, for Medicare fee-for-service patients. Naomi Fuchs is going to talk in detail about her arrangement in this quadrant, so I'm not going to go into much detail there. But I want to talk about the other kinds of arrangements that we might see. In the lower right-hand quadrant, you'll see global risk. And this is where health plans might contract with an IPA, medical group, other provider organization, and give them a payment that would be expected to cover all costs, true total cost, for both inpatient and outpatient services. So as you could begin to see, some of these contracting arrangements might include accepting accountability for costs that don't happen in your organization, happen with providers outside of your organization. And that's something you're going to have to pay attention to. So that, the global risk arrangement, I think, represents the highest level of accountability for total cost of care. Going to the upper right-hand quadrant, you'll see shared savings arrangements. This represents sort of the probably lowest level accountability, a good way to get started in these kinds of contracting arrangements. This might be an arrangement between a health plan and IPA, medical group, provider organization, where they're paying fee-for-service rates as usual, but it includes some bonus, some shared savings if total cost of care is improved. So the two takeaways on the contracting side is one, that if you're going to be entering these kinds of arrangements, you need to be prepared to accept responsibility in some way for services that might not be delivered by your organization. The other takeaway is that all of these contracts are based on some performance against target, which is supposed to represent the expected total cost of care of the underlying population that you're serving. And I think Naomi has a really interesting story about why that's so important to pay attention to when you're entering these contracting arrangements. So let's go to the next slide and say, okay, so if I'm a provider organization beginning to accept accountability for cost of care, what can I do? Where should I start? What should I do? So I'm going to take some time to share our lessons from the California Quality Collaborative work that was done, I think, last year, and is available on the California Healthcare Foundation website, which summarizes the lessons we learned from best practice interviews with 15 organizations. Just a little bit about these 15 organizations. We use data, publicly reported data on ACO performance. We use some data from IHA here in California to try and identify who does this well. And our interviewees included, of the 15 groups, they managed pretty much, somebody managed across all business lines, Medicare, Medicaid, and commercial. About 2/3 had that global risk. They had experience managing true total cost of care, which included inpatient and outpatient services, even though they did not own hospitals. These 15 organizations represented a wide diversity of structures, IPAs, staff model groups, foundation model groups, and some of them were very new to the experience of managing cost of care. Some were doing it for 30 years or more. But I think this means my takeaway here is that you can get started in this work and do it pretty well even as you're just starting. So let's go to the next slide and summarize some of the lessons that we found. First of all, as you all know, the first step to managing and improving anything is to measure it. And these 15 organizations, they were not measuring total cost of care directly because it's very difficult to get timely information on total cost of care so that you can actually make adjustments. These are the measures that they were tracking on a monthly, some were a weekly, monthly, or quarterly basis. So you can see that they were tracking utilization statistics that were highly correlated with total cost of care. A couple things I want to point out. First of all, that the first three measures, acute admits per 1,000, so that's how many hospital admissions per 1,000 in the population, the readmission rate, all-cause readmission rate, and the length of stay for each admission are all hospital measures. This brings to light that the first place that all of these organizations started was getting their hands around inpatient utilization. That was the most important driver of total cost of care. Then the other measures that they tracked were emergency department use, and then they were trying to get per member per month costs for their specialist services. So you might take a look at per member per month costs for cardiology and orthopedics as examples there. And then they were all tracking these measures against some kinds of benchmarking. Some accessed Milliman. You have to purchase these services. Milliman offers benchmarks that groups can use. And then the health plans who were contracting with the provider organizations also offer benchmarking reports. And so that's what they're doing to begin to measure and track their improvement on total cost of care. If we move to the next slide, once you've got your data set up, what are they actually doing to manage total cost of care? And as I mentioned, the most important place to start is on managing inpatient days. And there were 5 ways that we found these organizations were addressing hospital costs. I'm not going to go over all 5. You can read more about them in the brief on the CHCF webpage. But I want to give an example so you get a sense about how these are happening on the ground. And I'm going to use the last one, a structured, consistent, replicable case review meetings. And you can see they're extremely frequent, daily or weekly. And I'm going to choose this one because it's probably the least costly to implement. And regardless of provider organization structure, they were able to do this pretty easily. So these are case review meetings for patients at risk. So it's very structured. It's led by a physician who's comfortable facilitating these meetings. And they sometimes happen at the practice site in a primary care practice. They could also happen centrally at an IPA or MSO office. But they're always facilitated by a respected physician, and they include the team who might be touching these set of patients who are likely to be using a lot of healthcare services. They might be medically complex patients. They might be those currently in the hospital. They might be those recently discharged in the hospital. Each organization set their criteria for which cases they would review, and it's very structured, very accountable, so they can very quickly go through a number of patient cases and quickly decide what's going to be best for that patient to get them home and safe and their medical conditions well cared for. So that's an example of some of the practices that these organizations were using. If I go to the next slide, important foundations. We also, in the interviews, said that, there's a couple of, there's a number of things you have to have in place before you can really execute on some of the tactics that they described. We talked about data. Collecting and aggregating and reporting out data on the utilization measures that we just looked at takes some time and takes some focused effort. The other important boxes you see here, leadership and culture. One of the key points is that particularly the physician leaders of an organization need to be as comfortable talking about improvement in cost of care as improvement in quality. And that's a real culture shift. We also found that organizations that were already used to working in multidisciplinary care teams, maybe in their care transitions program or maybe as part of a PCMH practice, found that the transition to managing cost of care was very smooth and very easy. Those that had to build multidisciplinary teams took a little bit, it was a larger cultural leap to get to this place. And then alignment. As you might imagine, once you're focusing on cost of care, then you want to be able to change your reporting infrastructure so that everyone in the organization sees the dashboard of measures as easy as the quality, that you might want to change your compensation systems for administrative and physician staff. And also important is finding partners, because managing cost of care requires often, not always, but often requires managing services outside your organization. You want to be working with other institutions that share your interest in not just managing quality, but also cost. So finally, my last slide on benchmarks. I'm not going to go over the benchmarks, but those of you who are, might be interested in looking at your own data, here are some publicly available benchmarks for some of the utilization measures that we just reviewed. And you can take a look at this at your leisure. And before I hand it off, I want to just say that CQC will be offering a collaborative program in managing cost of care. We'll be creating a change package based on our best practice interviews and working with organizations who are interested in implementing some of what we learned. But most importantly, I'm going to hand it off now to Naomi Fuchs from the Santa Rosa Community Health Centers to talk about her really direct experience on managing an ACO contract. So thank you.
Thank you. This is Naomi. I appreciate that great introduction. I want to add to what was said earlier. In addition to running a community health center here in Santa Rosa, I also serve as the CEO for a local ACO called the Redwood Community Care Organization, and that's really what I'm going to be talking about today. So we can go to the first slide. Really, first of all, many people ask why a group of community health centers would start an ACO. And really, we were inspired to participate in the Medicare MSSP program to see if, with good data and dedicated primary care, we could achieve the triple aim. We have a fundamental belief that primary care will be the driver for success, for improved quality, a better patient experience, and lower costs. So we saw this opportunity. We thought that the Medicare MSSP program would really provide a place where we could improve our expertise, improve our infrastructure for implementing value-based model of care. It would be really the first time as a group of health centers we would have access to and the ability to analyze claims data for all services provided to a patient population, and to use that data for predictive modeling using a combination of claims data and clinical review. So essentially we were motivated to, we wanted to be able to transform care for our vulnerable population. It was a significant leap of faith, but we really felt we were leaping in the right direction. Next slide. So who are we a little bit? So we are a group of community health centers based mostly in Sonoma County, a little bit in one in Napa. Originally, we also had one private practice primary care physician, but that turned out not to be a good fit. When we set out to establish our ACO, we met and developed sort of letters of agreement, partnerships with our local hospitals and multi-specialty groups. We did not offer them to share in the savings, as we really all understood that we were making the initial investment, the health centers were making the initial investment, and the savings, if there were any, would be reinvested in the community health center system of care. Next slide. So what is the Medicare Shared Savings Program? There are a few requirements to participation. One is that you have a minimum of 5,000 Medicare patients. When we looked at our patient population data, we thought, of course, we have that many. When we went back and CMS analyzed our patient population, it was a lot closer. The attribution of assigned patients by CMS is complex and often difficult to discern whether that your patients are really going to be assigned to you based on what other kinds of services they were going for care, other providers. The other challenge was that community health centers rely heavily on nurse practitioners and physician assistants for the delivery of care. Those visits were not part of the Medicare attribution system. They required that every Medicare patient be seen by a physician. So that also affected our assignment. In order to share in savings, you have to reduce cost by a minimum of 2% and submit data on 34 quality measures. We opted for no downside risk, which turned out to be a good thing. And we received no funding to launch this program from CMS or the hospitals or grants until very recently. So the funding for the whole program really was through a lot of in-kind contribution from the health centers and our local consortium, as well as cash contributions from the founding health centers. And all of the program development came from the health centers themselves. So any of our complex care programs, our care transitions had to be funded directly by the participating health centers. So we really had a very simple, because we had limited resources, we had to focus on where our best opportunity might be for achieving the triple aim. And we decided to focus on reducing admissions and reducing readmissions while meeting our quality goals. So we evolved several care intervention programs in each of the health centers, including care transitions with health center nurses rounding in the hospital and following up on every hospital discharge within 48 hours, as well as complex care programs that identified high-cost, high-risk patients and provided intensive outpatient case management, including home visits, 24/7 phone access, social work, and mental health services. Next slide. So data versus analytics, or data versus information. Once we began the program, we started receiving CMS files that included every claim for our assigned patients, and thus the ability to start to look at total cost of care for each patient. However, these files were virtually incomprehensible on their own, and we realized quickly that the data we received from CMS would require a specialized data analytics tool to turn that data into useful information. We purchased the CCMR platform from eClinicalWorks because eClinicalWorks is the EHR that the majority of our health centers use. It took at least 1 year working with eClinicalWorks to make CCMR a viable analytics tool. I don't think there really is such a thing as an off-the-shelf analytics tool. We did, however, also receive quarterly reports from CMS that provided some aggregate information and helped support our cost data analysis and provided some comparison data. We also had access to health center data through data sharing agreements. So since we were all using the same EMR, we could actually go in and pull data and look at how each of the health centers was doing on their clinical quality measures. Next slide. So the first thing we looked at, and the first thing we really learned about, was about our patient population. So as you can see from this slide, a Medicare ACO in the safety net is vastly different from an average Medicare ACO. 41% of our patients are disabled. This means that they're under 65, but eligible for Medicare because of a disability. This can be a chronic disease, it can be a mental health disability, as well as a physical disability. Another 30% are dual eligible for Medi-Cal and Medicare. So they are over 65 and very low income. Only 20% are over 65 and not low income. As you can see in the traditional ACO population, this represents 81% of the population. So we have a really different needs and different responses to help achieve our triple aim. Next slide. So how do we use this data? We use it at a variety of different levels. Here you can see a macro picture of just looking at where are our dollars going for our patients. So it breaks it down by cost by provider type. So fully 30% of the costs, more than that, are for inpatient utilization, while almost another third is for outpatient facility costs, and just over 20% are in physician costs, both primary care and specialty care. And as we heard earlier, we understand that cost is driven by unit cost times utilization. In a Medicare MSSP model, we do not have any ability to affect unit cost. Providers are paid whatever Medicare pays them. So we are not contracting with our providers of service. We also have no ability to limit or channel or direct patients as you do in an HMO with utilization review or a limited network of providers. So the only opportunity we have for reducing cost is by working on utilization through care management and care coordination. Next slide. So we drill down deeper. We can look all the way into the patient level data, and we would send this to the health centers each month to help identify patients that require additional outreach or patients who could be considered for enrollment in a complex care program. Monthly data reports include emergency room high utilizers, high cost patients, high utilization, high risk. Low risk is due to a lack of serious health condition, but sometimes it's also because they're identified as low risk because we haven't well documented their conditions. So looking at this data, you can see Mary Smith has a very low risk score, 0.63, but she's been to the ER 5 times. Furthermore, you can see that the costs for Mary Smith are relatively high, having been to the ER so many times. So why is it that someone with a low risk is actually costing a fair amount? And then we can go and drill down even further to try to figure out what's going on in this particular case and how we might best respond. Next slide. So we drilled down a little bit to see what's going on with Mary Smith and why she was going to the ER and when and with what kind of diagnoses. And you can see it was a variety of reasons, some of which might have been better handled in a primary care setting, but she was going on Saturdays and Sundays. During the week, she had slightly, potentially more or risky diagnoses, but clearly we probably should reach out to Mary Smith, make sure she's well connected with her primary care provider, and see if she understands how to contact the health center after hours. So we can use this data on a macro level. We can design programs and figure out where relationships we need to collaborate, comparative data and trends. The claims data we can use to really work on patient-level interventions. And as you can see, we need the claim to achieve the triple aim. Transforming care requires access to data, and participating in this program has provided us with unprecedented access to patient data. We could not get this from our Medi-Cal managed care partner or any of our health plan partners. So it really provided a unique opportunity to have the data improve care, outcomes, and costs. Next slide. So what have we learned from some of this? One of the main lessons we learned, and it goes to that issue of leadership and culture, is that there's been a really fundamental shift in how we approach population health. In the past, each health center succeeded or failed solely based on their own performance. In the ACO, it didn't matter where our patient's primary care was provided. The cost and quality of that care affected all of us. So it really strengthened our organizational alignment, which is, as we heard, is critical to success. We worked more closely together, we supported each other, we shared successful programs, and monitored how everyone was doing across all of our clinical sites. The downside really was that resources and expertise to provide significant care interventions and use the data effectively at the provider level varied widely among the health centers, depending on size, staffing, financial resources, and competing projects or programs that were going on for each of the sites. Next slide. But clearly, we need the data to drive strategy. I think it was a completely appropriate strategy to try to reduce hospitalizations and readmissions. This is the #1 cost. It also pointed out where our partners were that we needed to work with. We focused on coordination of care with acute care hospital partners in our community. And we learned a tremendous amount about the art of risk stratification for patients. The data can point you in a direction, but it's really critical to look at the patient chart and talk to the primary care provider, do that case review that Diane was talking about to get a full picture of the patient needs and what's going on. We created comprehensive, complex care management programs to support the highest cost and highest needs patients. However, we also learned that if the goal is to reduce costs, it's necessary to focus on those patients who are ready to benefit from comprehensive case management. We spent a fair amount of time and energy, often with patients who really were not ready to engage in improving their health. And if we want to benefit the patient and the system, sometimes it means identifying those people who are really ready to make some changes and take some steps in their lives. So how did we do? We actually had some successes, and we learned some things from our failures. As you can see, we have a much lower than average rate of hospital discharges already compared to all people participating in the MSSP program. But we also still have been successful at reducing hospital admissions a little bit. And while we did not reduce all-cause readmission rates, we had a significantly lower than average rate to begin with. And really, at this point, when looking at our managed Medi-Cal patient population, our all-cause readmission rate is under 10%. Compare that to the data you just saw that looked at about a 16% rate across managed Medi-Cal as a whole. So, next slide. one of the things we really learned from looking deeply into the data was that we found that there were significant hospital costs occurring at psychiatric hospitals that we had completely been unaware of prior to having this data. In our county, the county mental health department admits the majority of psychiatric patients, and the primary care provider is never notified, consulted, or included in the management of the patient. So we now have a new strategy to work on, which is to develop relationships with the psychiatric hospitals in our area, and specifically with our county mental health department to work together to coordinate care. You can also see from this data that we have a psychiatric hospitalization rate that's more than 2.5 times the average. A great opportunity for improvement. Next slide. So a recent article in Health Affairs analyzed those ACOs that were successful at achieving cost savings versus those that were not. And one of the primary predictors of reducing cost is having a higher than average cost to begin with. So our benchmark in this program was $8,500 per patient. Compare that to the lowest Medicare county that you just saw in previous slides of $11,500. So our cost per patient has started at a very low rate, and it made it extremely challenging to reduce costs. So we now use our ACO as a learning lab for value-based care. And we've advanced significantly in our ability to use data for predictive modeling and developing care strategies, although there's still much more to learn. Working with our hospital partners on care coordination has had a profound change in how we collaborate around patient care. Patients are getting much better post-hospital follow-up, resulting in this much lower readmission rate, as I said, of under 10%. Furthermore, we are making a significant difference in the quality of care and our patient experience for people who have often been marginalized and left without the support they need to succeed on their health journey. Our challenges really are continuing to learn how to use the claims data, learning how to optimize our data analytics platform, disseminating data to health centers in a digestible and actionable formats so that people can put that data to work. And as I mentioned earlier, just trying to standardize the resources that are applied across all of the health centers has been a challenge. Now I'm ready for questions.
Great, thank you. So from here, we are going to go into discussion, and as people are able, if you would please send in your questions via chat. Canel, I don't know that my screen's allowing me to see all the chat or any questions that have come in already. Do you have anything sitting there?
Nothing has come in yet.
Okay.
So feel free. The chat and the question box are open for anybody who'd like to drop their questions in there.
Great, great. And we're going to let the slide sit at the successes and challenges slide from the Redwood Community Care Organization. I think it's a good slide to look at as we get Diane and Naomi in conversation here, and then also we will weave in your questions as they come in. So one of the things I wanted to hear the two of you talk about together is get back to where organizations can get started. So if people listening, they know they want to work on total cost of care, where would you suggest they start? With the data, with the partnerships? Is there a clear pathway, or what are some things they should consider?
I would say you absolutely have to start, if you really want to focus on the total cost of care, you have to start on getting that data because it's not easy to get and it's not easy to manage. If you're looking at reducing that cost, then you need to start developing those relationships with partners and defining what kind of strategies are going to help best bend that cost curve. But you won't know where to focus, and you won't know if you're having an impact if you don't have some of that data to start with.
Hey, this is Diane. I really second what Naomi said. I think she was really smart in setting what priorities they would focus on. and you need the data to be able to do that.
Great, thank you. Do either of you have, Diane, do you have an observation as somebody who helped lead these interviews of national leaders in this work, or do you either of you have questions for each other about the work or next steps?
Well, I just like to step in a little bit and go back to what Diane was saying about leadership and alignment, because really it takes such significant collaboration to make these kinds of systems work, that if your motivation and your commitment to the vision and mission of the program isn't aligned, you're going to be going off in a lot of different directions all the time. So really starting with that core base of why you're doing this and what you're trying to accomplish and being very clear on those objectives. I think for us it was challenging at first. We were focusing so much on cost, and when we realized after we got our first benchmark data back that our cost was already so low, it was very unlikely that we were going to actually bend the cost curve. In fact, we saw our costs going up, probably because we were starting to pay attention to a lot of patients who needed serious care. That we had to adjust our expectations and adjust our reason for doing this, from thinking we were going to make some money to thinking that we were going to have learn a lot about value-based care and be prepared for the models of the future.
Yeah, I'm curious, Naomi. This is Diane. A question for you is: can you describe a couple of sort of turning points in that cultural journey? You know, culture can be such an amorphous word, but can you recall some sort of stories about where you saw some of that change?
Well, I remember we had several sort of strategic planning retreats with the health center leadership and both clinical and administrative leadership along the way. And the first time we started really presenting the quality data, and we always did it unblinded. You could see everybody's quality, who was doing what, where. And understanding that when it came to measuring our work, it wouldn't matter where those patients were. It wouldn't matter that such and such a health center was stellar at controlling hemoglobin A1C and somebody else did a great job at hypertension. Patients would be picked randomly across all of the health centers to be measured, and that everybody's performance mattered. So yeah. there was a big shift there in saying, oh, this is one patient population, not individual provider groups, patient population. And that was a very transformative moment.
Yeah, one of the stories we heard, how particularly important the CEO message was, particularly for organizations that were just starting this work, who were just starting, that the amount of effort it took from the CEO and physician leadership to say, we're going to go, that leap of faith that you described, we're going to accept responsibility for the entire triple aim, and we're going to be moving away from a fee-for-service based program, if that was in most cases, that was their original payment system, toward a value-based system, even though we know in the short term it may even hurt us financially. The importance of that message and the consistency of that message from the top seem to be very important.
I would agree, and as a community health center, we made a significant investment in a whole care coordination department, which required support from our board of directors as well, and it was really seen as not only the right thing for our patients, but really preparing us for the future.
And Naomi, I know that the clinic, the Santa Rosa Community Health Centers, has been doing different complex care case management programs for different populations, like, for example, specifically for homeless folks, for years. Can you say how, I know it gets this clearer spotlight and maybe more partners committed in a new way when it transitions to include a focus on total cost of care, but can you describe that? What did or didn't change in terms of the care team and what their activities were?
Yes, actually, there's a couple of things. One is you can actually start to see where are you making having an impact, right? You may be spending a lot of time with a homeless patient who is mentally ill and has a substance use problem, and sometimes that intervention changes their lives and they're not going to the ER anymore and they're stabilized and found housing, and sometimes it's not, and we had to say. Okay, now that we actually have the data and we can see how often that patient's going into the hospital and how often they've been to the ER and is their cost of care changing, that we may have to say, okay, after 4 to 6 months of working with the patient where nothing's happening, we have to move on. And maybe we'll come back when they're ready to make some changes. But it was a challenging thing to have to do, but really limited resources. A triple aim goal, you have to decide where to put your energy. And we couldn't really know what the impact was until we had the data to see what was happening with those patients.
That's great, thank you. And I also want to see if there's anything else we want to talk about the kind of the getting started topic. There may be no more there, but to get folks who are listening in with us to give us some information about what you're thinking, what you're going through. If you don't have any specific questions, that's great. I'm interested to hear if you could type in where you are in this work. Are you pre-contemplation? Are you thinking seriously about engaging partners in this way and starting to really do this hard work that Naomi's talking about for getting total cost of care data? Do you have partners already set up for this work? If you put in a few words about your status with working on improving total cost of care for a population, that would be interesting and I think helpful for the last 10 minutes we have here. Let's see. So as we wait and see what people say about that, Diane and Naomi, do you have any other thoughts about any other questions you want to ask each other, and if not, other thoughts you have about helping people get started with? Maybe Naomi, you said start with the data. So what's next if you start getting data?
Well, start with the visions for what you want to do and where you want to go. Really, think about what the challenges in the environment are coming forward. So we've got Medicare coming out with bundled payments. We've got most of California in the Medicaid population in a managed care plan, many of them with significant savings opportunities or pay-for-performance opportunities. So where is it that you're trying to take your organization, and what do you need to be prepared for success in the future, right? The world is changing, and you don't really want to wait too long to get ready for that new world, or you'll be behind the curve. So I think really first it comes with what's the motivation, what's the burning platform to make a change, why should you be doing this? And to me, that's the reason. As leaders, we're trying to always position our organizations for success, not just this year, but 3 and 5 years down the road. So once you've made that and identified that as a goal and a direction and a vision for your organization, then you go look for that place where you can start getting that information. And maybe there's a health plan partner, maybe you're getting into capitation and you're taking on risk. Maybe you want to participate in ACO and you want to understand that. But I think it has to start with a clear vision and direction, and then you can go find the partner that can deliver the data. And it doesn't have to be for everybody in your organization, right? Working with a small population, subset of your patient population actually is very helpful. You actually have a manageable size of people that you can try to intervene with and see what kind of care interventions make a difference. Who are your patients? Do they need more mental health services than medical services? Are they elderly and really, doing in-home assessments for fall risk is what you need to be doing, or providing socialization for people who are going to the ER because they're lonely a lot. It's really knowing what your patient population needs.
Great, thank you, Diane. Any other thoughts on that? Momentum, leadership, vision?
Yeah, I'm thinking also of some of the more advanced organizations that we talk to. It's definitely getting your internal house in order as a first step, getting the data and turning it into information, as Naomi said, and then setting up your reporting and your incentive systems internally. And then once people felt like they got their hands around some of the inpatient utilization issues, they dug into the data to see where their particular issues were. We found that after that, the roadmap wasn't so clear. It might have been generic prescriptions. It might be cardiology services. And we saw organizations beginning to really focus on external partnerships, negotiating a capitation arrangement with the cardiology group, or developing narrow networks of specialists who shared the same philosophy of patient care, were willing to invest in communication systems back and forth about that patient's care plan as they begin to become more sophisticated in managing cost of care.
Great, thank you. Any other stories or observations from that, from the nitty-gritty of building those relationships? You've mentioned several good suggestions and ideas, but anything about the way that those relationships come together, leading with, I mean, Naomi, that sounds like your group definitely led with the vision. I'm wondering where maybe kind of the vision mission part of that, building a richer, deeper, more targeted partnership comes relative to, I don't know, business negotiations about how the funding may be shared differently among partners.
Well, as I said, we didn't have an opportunity to pay people differently, right? In the Medicare no downside MSSP program, but really the hospitals were just as interested in reducing readmissions as we were, and so we were able to set up monthly meetings with the hospital discharge planners to start with. We now get automated admit discharge transfer feeds from all of our hospitals, so we know instantly when patients are being admitted or discharged from the hospital. We've now got the nurses rounding in the hospitals to help with that transition from hospital to home. So the level of cooperation and collaboration with the hospitals has just gone way up since we started this, and it had a reason to do that, right? I think it's improved the systems of care across our whole county by doing it. Because of course, what we're doing for this small patient population, we're also it spreads over to the rest of our patients as well.
Right. Diane, anything to add on that topic, or something else you think people need to know? We've got about 3 or 4 minutes, and then we'll wrap up and sign off.
Naomi, I want to follow up on the point you just made. So for your organization, as you mentioned, it's about 8,500 patients that you're working with now. Are you finding it's shifting care for patients outside the ACO?
Absolutely. I mean, we're not just rounding on 8,500 patients who might be in the hospital. That would be not worth our time. So we're rounding on every patient in our entire, we have almost 50,000 patients. So at any given time, there are definitely people in the hospital, and so we're taking what we've learned and the relationships we've built, and we're applying it to all of our patients. We don't have the data, but we at least can take the interventions and the strategies and apply them across.
Mm-hmm. Yeah, that's pretty exciting.
We're now working on the ability to actually get automated admit discharge feeds right into our electronic health record. So primary care providers notified when their patients in the hospital.
Kind of a holy grail.
Yeah.
and the interest of the hospital in investing in a valuable IT resource to be able to do that. How did you make that happen?
Well, a lot of years of building relationship, really. I think, they have staff that's also doing care coordination, case management, knowing they really don't want people showing back up in the hospital, either in the ER or for readmissions. It's not good for the patient, it's not good for the hospital, it's not good for the system. So they're very grateful that they know that that's, someone who needs follow-up will get a telephone call, maybe a home visit, social work, transportation to their specialty care, that they're going to reconnect with their primary care. So they really see it as an investment in a sort of virtually integrated system of care where there's nobody falling through in these handoffs from one institution to another.
That's great.
That's fantastic. Well, thanks to you both. We're gonna wrap up now. Did not see, unless there's something in the chat that I'm not seeing. Not seeing any chatting going on. So I hope people are listening, but just not having much to offer.
No, I didn't see anything else come through.
Okay, thank you. Okay, so I want to thank again Naomi Fuchs and Diane Stewart for that great discussion and for sharing all their knowledge and experience with working on total cost of care. As Naomi was alluding to there, definitely more of this work will be coming down the line for all of us. So, those organizations that are in the lead really value their experience and their generosity in sharing what they've learned and their progress along the way. So thanks again to both of you. It's been fantastic. Please, again, if you're not on the CHCF, the California Healthcare Foundation's California Improvement Network mailing list, I recommend you do that. You'll get emails from the CIN about once a month. It's not a high volume list, but activities coming up that you may want to take advantage of. There's going to be opportunities to join a program already underway supporting safety net primary care organizations who are building medication-assisted therapy programs for addiction. So that's really related to today's topic. We're also working on future webinars, including some that we're looking at doing on new technology tools, the best way to use email and other asynchronous messaging with providers, case studies and use cases for texting and other technologies that people are still trying to figure out what are the best ways to use these new technologies in primary care to improve population health, and other opportunities coming up. So want to again thank you all for joining us, thank our speakers, and that is it for today. We appreciate your time.
Thank you, Hunter.